and after that we can network for a little more. There is a raffle entry, and so for those of you that have not put a business card in, please feel free to do it right now, because after this you won't be able to do it. So then you do have a raffle entry. We can't, these events don't happen without sponsors, and so a few words about our sponsors. Blue Banks is our sponsor, Renega Ad Builders, and also the beers from Off-the-Bike. So, we also have our community party. So, this is you're all sitting in the Houston Technology Center. The Houston Technology Center, for those of you that don't know, is one of the largest business incubators in the state of Texas. In fact, it's one of the largest ones in the country. And right behind me, there's a wall there. Those are all the folks that have companies that have graduated from there. So the incubator basically allows people to come into the Houston Technology Center. They provide resources, they provide access to funding. So there are a lot of folks that do very well here. We have the Greater Houston Partnership, as well as the Center for Houston's Future. A little bit about speakers. We got Deepak Chaudhry today with us. He's from the Greater Houston Health Connect, and he'll be giving the talk today. We also have Nicholas. I can never say his last name there. I don't know what I'm trying to butcher it again. Economitis. Right? I'm like a rich person. He is. He's going to give us some information about insurance and underwriting and hopefully we'll learn about cyber issues. Turn the music off. And we have Jeff Rankin from Principal January Advice. That'll be an interesting job. Talk about funding and angel investing. So those of you that may be interested, I'll be here in session to attend. Okay, so let's talk a little bit about Deepak here. All right. So he's coming with the Greater Houston Health Connect. I'll let him talk about what the Health Connect does. I don't want to steal this from them. But he's worked with several companies, Nexus Health Systems, Venus Technologies, and I think this is one of the larger projects he's been involved with. Is that 5.66 million?
5.6 is the version of it.
Oh, the version. So basically,
it was a $15 million project.
So I'm going to let you elaborate on that. So that's a whole. Sounds very interesting. The next tech project. And he's from Penn State, living from University of Toronto, and he's actually going to be the president this year for the HIMSS Houston chapter. So HIMSS is a large healthcare. It's a large institution of healthcare professionals and how many members do you have? I think in the Houston chapter.
The Houston chapter we have over 5,000.
5,000, and I think across the country we have. I know the Orlando campus has 20,000 to 30,000.
We have about 50,000.
50,000 people. It's a huge chapter. So anyone interested in the healthcare business needs to be part of HIMSS. And he's also on the Greater Houston Cybersecurity Task Force, which is a task force that Ramesh actually heads. Deepak's married with 2 young kids. Right. How do you get out of this now? 5 and 3. Live there.
Exactly how you get out.
That's why you need to get out, right? Yeah. And there, yeah, you have it golfer. What's your handicap?
I don't have a handicap.
Right, you doesn't have a handicap. Okay. Well, without further ado, let me bring Deepak to stage for his presentation. Thank you.
Thank you, everyone. So just recapping the agenda, we talked a little bit about HIPAA. There wouldn't be a healthcare conversation if you didn't talk about HIPAA, right? The High Tech Act, about Greater Houston Health Connect and what we actually do. Talk a little bit about the topology makeup of GHH and how our data communicates. Some clinical workflows, privacy and security, and then talk a little bit about the industry as a whole and the data breaches that we've seen in 2015, what's coming up in later in 2016, how we can improve from the lessons learned that we've had recently, and talk a little bit about a newly adopted common framework called HITRUST. So, looking at other industries, this is how we bank, we buy, we fly. Everything's organized, everything is systematic, electronic. But in the healthcare industry, it's very different. In healthcare, this is how we practice medicine. Is that correct? I know there's a physician here. Is that correct? Okay. So, it's not organized. The data is everywhere. It's handwritten half the time. The large enterprise hospital systems have converted over to EHR, electronic health records. But the smaller primary care docs, the specialists, have not. This is how they practice medicine today. So taking a little step back and talking a little bit about HIPAA. HIPAA was formed in 1996. Okay, those standards are still around. I don't know why this keeps forwarding. Those standards were built in 1996. Okay, and it's all around insurance affordability and accountability. And that had several mandates, which included, healthcare transmission of billing, along with keeping the patient data confidential and protected. Okay. Now, there's been several revisions of HIPAA. However, it's not fully a standard protocol used today. We use a blend of different protocols, HIPAA being one of the foundations, which we're going to talk about a little bit more. Then in 2009 came the High-Tech Act. This keeps moving forward. All right. During this time, in 2009, the government decided that we need to be able to automate health information records. And how are we going to be able to do that? By providing funding for physicians to be able to adopt to health records. So an influx came in what we call meaningful use dollars. Have anyone heard the term meaningful use? Okay. And that was an incentive program by the government for eligible providers for Medicare and Medicaid, along with hospitals to go to adopt to EHRs. So, as you can tell, 2009 is a lot longer ago. And there's an influx of all these docs trying to get these dollars, say, I need a medical system, I need a medical system. So what we're talking to you, what we're talking about is, what goes around the medical system? What's involved? And then, also in 2009, one of the mandates was, you've got this electronic health record, you need to be able to show how you're utilizing it, what the data does for you, the quality metrics around that EHR system and the data that you're collecting. And so that's how these criteria for meaningful use came about. And then also, how are you sharing that data? How is that PCP be able to share that data with specialists? And how going from one hospital system to another hospital system can that data be shared? And in 2010, that's when Greater Houston Health Connect was founded by the Medical Center. So the vision of the Greater Houston Health Connect is to be able to connect all venues of care. Right now, if you were to go to a freestanding ER clinic in the suburb of Houston, and you have some sort of reaction, you go in there, do you think they'll be able to pull the medical record up from Methodist or from Herman? Chances are, no. How important is it for them to be able to see your medical history when you're at a point of care in an emergency situation? Very. And so that's where Greater Houston Health Connect comes in. So we have worked very, very hard to be able to provide a use case, and many use cases, on why medical transmission of data is required at all venues of care, whether it be labs, pharmacies, hospitals, and primary care physicians. So this is a slide just on value. You already know the value from a clinical data exchange perspective, but also it's able to achieve meaningful use, if you're familiar with meaningful use, there are 3 stages. The third one is not fully matured yet, but stage 1 and stage 2 of meaningful use helps physicians that receive those monies to be able to meet certain quality metrics to be able to get those reimbursement dollars, because those reimbursement dollars are not being paid up in front. They're through each stage, you get a certain portion of those dollars. You know, being able to receive patient treatment and patient information in real time. I mean, the example I gave at the ER, three-star ER clinic around the corner. You know, if there's another one or you are presented there, you need to have that data information that available. Redundancy in tests and imaging. You know, you go to Netflix today and say, I've got this issue. They'll go through the diagnosis and they'll recommend all these labs and tests you have to go through. You're like, I just went through it in MD Anderson, you know, a month ago. Can you pull that out? And so you can see where the insurance companies are getting frustrated because they're now having to pay out for duplicate tests. Improve quality and safety of patients by reducing medication manipulation. Obviously, that's a given. And then also being able to provide that clinical decision support at the bedside. So when they're presented at a hospital setting, the patient has the full medical record, not just a portion of it based on who you're seeing in that surgery. So GHH currently serves the 23 counties and growing. There are 5 different health information exchanges around Texas. Houston being one of them, Austin, San Antonio, Rio Grande Valley, and another one in the southern border of Texas and Mexico. And so we are providing this clinical data exchange, but as you know, we're concentrating a large metropolitan city and being able to branch out to smaller urban, rural areas. This is our current participation list right now. It's growing every single day. I'm sure there's those on here that you're familiar with that you may be also a patient at. These are organizations that are currently live on our network today, and we're growing every day. So to talk a little bit about communication mechanisms and how they are connected. So Health Connect is actually our infrastructure and our what's called a health information exchange platform is hosted and developed by an organization called Medicity. So they are an outsourced vendor to be able to host all this data along with infrastructure. So MD Anderson, for example, Methodist, they all tie into Medicity's infrastructure. We don't actually house infrastructure here in Houston. Okay? Along with your PCPs and specialists and so forth, the way the data transmission currently works is that there's a secure VPN connection from, let's say, MD Anderson in this case, back to Medicity who's in Utah. And that VPN connection shares data, holds secure data in transmission, which is in regards to admit, discharge, and transfer data. So that's basically all the patient demographics that are going through that pipe. And that helps to distinguish and confirm the John Doe that's at Methodist, for example, is the same John Doe at MD Anderson. Okay? And that's how we're able to do what's called a master patient index match to know that this patient has been seen multiple places within the participation community. What's also really important to note is that in this AT feed, there's consent values. And we'll talk a little bit about that as well. But the patient needs to consent in to share the information. If the patient says, no, we do not want to share that information, that consent value is sent over and we walk out, and we store them so no one else has access to that data. Now, another use case is, I talked a little bit about being presented in the ER, But what happens if you're on vacation in Denver, Colorado, and you get into a skiing accident, and you go to a hospital? They don't know you leave. They have no records. How do they get a hold of your records of the trauma? Immediately, because we know that the other option is faxing the records. And you can only imagine getting a physical record, sending it through a fax machine, and going through this process, how long it will take. So we've got a connection to what's called the Health Information Exchange in Texas, which is the network of networks. It's a statewide connection, and all the other health information exchanges in Texas are connected, like San Antonio and so forth. And then they connect to the national body, which then connects all the other state level HIUs. And that's how they will get the data and transmit from the Colorado Health Information Exchange to the Texas Information Exchange back to us for that query of the patient record and send it back. Okay. Any questions regarding this particular setup and diagram? Yes, sir.
So just where there are connected hospital here and in Colorado, that's working today, where if you're in there in real time, those are showing us.
Assuming that that Colorado hospital is actually a participant in the network. That is correct. Now, there are some states that are slower to adopt, and we're seeing that not all the states are connected. The VA is connected, the DoD is connected, but that will change because DoD is changing their EHR platform as well. So that may change. But as of right now, we have a whole laundry list of statewide entities and privately held entities that are connected. Yes, ma'am.
If the patient opted out of sharing the information, what would the hospital see? Would the hospital see that when they go to run it?
The hospital see no patient found.
No patient found.
Correct. They would not say that there's a patient record available and you just can't see it. It's just an information found that the human existed. And we'll talk a little bit about the opt-in, opt-out. I'll clarify on that. Yes, sir.
So is this kind of like a just-in-time VPN tunnel into the record within the hospital? So it's not like there's a virtual cloud out there with all these records on it. It's okay, we have patient John Doe.
It's a query and retrieve, so it's presented at the point of care.
Right.
Correct. So now, that's a good question, because we are what's considered a federated hybrid model. And what that means is that we actually, in a lot of cases, don't house that data ourselves. We're just a conduit for transmission of that data from point A to point B. So there are some health information exchanges that say, we want you to house the data and store it from a performance perspective and so forth. Now, keep in mind, when this was founded, when our organization was founded in 2010, you've got C-suite executives from the medical center, right? So you've got MD Anderson, Mass. St. Luke's, and all the other organizations sitting in one boardroom and saying, we need this clinical data exchange. But yet, they're not competitive. And now we have this entity that's the middleman, going to be hosting and holding all the patient information. So we want to be able to have clinical data exchange for the sake of the patient, but we don't want any entity to hold our data except for ourselves. And so that's how the model came in, saying that we're not going to store the data, we're just going to transmit the data. So it's at rest and in transit. Now, also keep in mind that, 6 years later, those discussions have changed. And as the model for payment performance is changing, going from a fee-for-service model to a value-based model, the hospital community is looking back at these announcements and saying, I know 6 years ago we didn't want you to hold the data, but we kind of want you to hold the data now, because we want to do analytics on that data. And right now we can't. And so there's been a lot of discussion at the research hospitals like MD Anderson and Baylor saying, if we had access to data, we'd be able to treat our patient population involved with that at a community level, not just from hey, I'm a patient at XYZ hospital, but at a community level. And be able to see trends, right? And say, oh, there's an outbreak in Zika in this zip code, and take a look at the symptoms around Zika for the zip code, and be able to alert public services. So that's one very small use case that you see for what they call population health management and data analytics in healthcare. Yes, sir.
So I understand that the secure transmission is one up, but how is authentication handled with all these people having access?
So the authentication is from a provider perspective on querying for that data. It's transmitted through their EHR. So their EHR has, in some cases, two-factor authentication, but some cases it's a login and getting access to the portal to get a login. So within the largest health EHR that's in Houston is called Epic. And Epic, they use a portal within Epic to get a query for this data. And there's authentication mechanisms that are utilized because at the end of the day, this data that you're querying is for 3 different things: PTO, payment, treatment, and operations. Not for marketing, not for sales, not for, hey, I know that cancer patients down the road, I want to try to steal them back to my hospital. It's one drink at a time, one patient at a time. Yes, sir.
How do you overcome if it's Epic versus Cerner versus Allscripts versus whatever their
Good
flavor of the day
question.
is?
And that's our biggest challenge. Connecting all these disparate EHR systems is the biggest challenge to our existence. And keep in mind that there's standards, right? There's standards for what we call HL7 transmission data. ADT messages are standardized, and also continuity of care documents are standardized as well. However, you get into those systems that are not standardized, and that's where you have to get a little bit creative on how you're going to connect them. And that's why the medical community is looking at Greater Houston Health Connect to say, we've got all these different health EHR platforms that are out there. We need to talk to each one of them because guess what? I'm an MD Anderson employee or physician, and I'm using Epic, but when I go see patients at Perman, I'm using Cerner. And I want to be able to transfer that data and exchange that clinical data. So there's protocols that are utilized for the standardization of that data transfer. I'm going to continue to get on with the other questions later on. So there's 3 different services that we currently offer as an entity. We talked about clinical integration, which is sharing of clinical data through continuity of care documents. But we also provide medical image exchange as well. So if you've got an X-ray stored at St. Luke's and you're now at MD Anderson, or if you're at Methodist, they can pull that PACS image, an X-ray from St. Luke's into their network and store it for diagnosis. And that's all using the same protocols, along with secure messaging. So that's what we call a poor man's way of sharing clinical data, is using secure email to be able to send data. And this secure direct messaging really came up for meaningful use because they wanted a cheap and expensive way to say that, yes, we meet meaningful use criteria and we can share clinical documents via an electronic mechanism. Not fax, not mail, through email, security. So a little bit about the workflow of the patient. The patient provides consent for clinicians to share their data, payment, treatment, operations, which we talked about. The clinician asks the patient community record through their EHR, through Epic, through Cerner, through Allscripts, or through a Health Connect, through our portal. So we have a provider portal. So for organizations that do not have, that are not connected to us, for example, we have freestanding ER. If they are a participant, they can log into our web portal and query for that patient based on last name, MRN. And then we have in our platform, we have a MPI, master patient index algorithm that matches that patient. So based on that criteria, whether it's the criteria being, first name, last name, social, phone number, address, and a few other criteria go with it, that gives us a 99% match, and then it downgrades based on the information, the less information that's available. Okay? So that's what we currently have to offer, and that's how our clinical workflow works. One thing we're trying to increase is the quality of the data. So right now, these are all the different data elements that may be available in the continuity of care document. Patient demographics, alerts, problems, procedures, but that data, as you guys know, is only as good as if it's submitted. So a lot of times, we'll get a clinical care document in transmission, and the doctor would say, I was really looking for the medication history. I don't see it from St. Luke's. It's because the physician or the scribe or the clinician didn't enter that information in. So we're having to go back from a utilization perspective, an application perspective, to talk to the clinical quality folks and say, we're missing data when you're sending it. And that's, as you can imagine, an interesting challenge as well, because now we're telling physicians how to do their job. Right, doctor? So, you know, mentioning before, the quality of the data is not there. You know, a lot of these systems were put to meet the government guidelines. Otherwise, their reimbursements would be cut over time. Medicare, Medicaid dollars would be gone from the reimbursements. And so these systems were put in place to meet these guidelines without thinking through what we're actually transmitting. And so meaningful use, stage 2, helps now dictate the quality of that data. And we're starting to see improvements of that data. So talking a little bit about privacy, going back to the patient's consent. You know, we have a business license agreement, a participation agreement with all of our organizations. And as I mentioned before, this patient consent is a global consent. We only hold one single consent, and that's the base expression, which is based on the date and time stamp. So, for example, if you are seen at MD Anderson and they ask you, do you want to participate in community-wide record sharing, you say yes. Tomorrow, you go to Methodist and they ask the same question at registration, and you say no. That latest expression is going to be held within our system. And we're not going to share that data because the latest expression was no. Now, keep in mind, there's also caveats to that as well. So, we have a, what they call grade class functionality, saying even though you've consented no, but we know that you've been seen at Methodist and you're in an ED situation, we can ask your loved one, saying, we need to diagnose this person, he's in the ED at St. Luke's, can we grade class? And as long as they authorize it, we can then get that record for the treatment of the patient, not for anything other purpose. Not for operations, not for payment. Okay? And there's obviously signatures that are required to grade that class. Any questions regarding opt-in or opt-out? Yes, sir.
So regardless of whether they opt in or opt out, you hold on to the information of the EHS, right?
Correct. So that demographic data in the ADT, the patient's name, insurance, social, phone number, address, because that's who we know, that's how we know who you are. That stays. But the clinical data is not available to us. So we're just querying all our participants to what they're doing. So I talked a little bit about this. You know, we've got secure VPN for that admin discharge and transfer fee, both at rest and in transit. We're using a web service connection to be able to exchange continuity of care documents. We've also been through, it's called the Electronic Health Care Network Accreditation Commission, EMAC certification, which basically says that you are authorized to be able to transmit clinical data to the state of Texas and beyond. And we are in the process now of going through a high trust certification. I want to talk a little bit about that as well. As I mentioned, our data is hosted by an organization called Medicity in a VL West location in Colorado. And obviously we have audit logs and being able to capture those authentications that we want to know who accessed the data when, because you know, St. Luke's will ask us from time to time, saying, Deepak, I want to see a log of all the patients that have been accessed on this day and within this facility. And we provide names of which clinicians, which physicians access which patients on that day, especially when it comes to VIPs, right? And VIPs are not just important people that are politicians and celebrities, but also there's VIP policies put in place for other staff members in the hospital setting. So if you're a normal permanent staff member, you can't just go into your EHR and look up the next clinician that works beside you. They're considered a VIP. So I'm going to digress here a little bit and talk a little bit about current industry trends that we're seeing in data breaches. And I'm not sure if you guys are familiar, but the largest data breach happened in 2015 with Anthem Blue Cross Blue Shield, impacting 78 million patient records. Okay, but the combined total of all the patient data that was exposed to breaches in 2015 made up 111 million patient records. That's a third of the U.S. population. And these are just the top 10 health data breaches for 2015.
Several Blue Cross Blue Shield, are they related?
They are. And so, talking a little bit about these data breaches, these in 2015 it cost the industry $5.6 billion. You know, and I think I mentioned over in the previous slide that hacking IT incident represented 21% of all breaches, theft represented 29% of all breaches. So, you know, and this is, I guess, my personal issue with the healthcare industry that we face today is that if you have enough insurance, cybersecurity, cyber insurance, to be able to cover those breaches, how seriously do you think those breaches are going to be taken? So in this case, Anthem had close to $200 million in cybersecurity insurance. So when they were fined for their data breach, they were covered, so there was zero financial impact on Anthem for that data breach, because they had no cybersecurity insurance. Another thing is that Health and Human Services receives, 18,000 complaints in 2014, but they only took formal action against 6 of those complaints. Now, I'm sure all 18,000 were not legitimate complaints, but look at the ratio here for the actions taken against the complaints that were given. So I'm not sure what the market value for credit card numbers is, but I'll tell you what the market value for a complete health record is. It's $500 per health record that you get in the dark web. It's a lot of money per record. And so what are they doing with that, with these records? Insurance fraud, number one. A great article that was posted regarding a cyber attack for a large hospital system based out of Boston. The Chinese entities stole 2,000 patient x-rays and give them out to foreign nationals of China so that people could not meet the regulations for their health screening to be able to get visas. And so they substituted those x-rays for them and been able to get them travel visas. So, how are hackers able to get in? They're able to break in through the number one, patient portal. So if you're a patient at Methodist or at MD Anderson or any other large enterprise hospital system, you're presented with a patient portal where you can log in and take a look at your vitals and take a look at your last screenings and your labs and so forth. Well, hackers were able to hack into that portal and they get access to the medical record. third-party apps. I mean, if you go to the App Store right now, you know, you can download a medical app that's you know, related to your Fitbit or related to any sort of treatment that you're tracking. Has that mobile app been validated? Because a hacker can get access to your phone and be able to get to your record. Or better yet, to the back end of that mobile app and be able to get to those records. Everyone knows ransomware is on the rise. You know, in a previous engagement, we actually were faced with ransomware. And so the question is, do you have the money so that they can decrypt your data? Or do you actually do something about it? We got government agencies involved. And guess what the government agencies told us? That's up to you for that. We can't help you. Okay. Unsecure, unencrypted physical media. There was a breach not too long ago, maybe 2 years back. MD Anderson had a data breach because an attending physician who was taking the metro in the medical center left their laptop on that metro. Non-encrypted. Excel spreadsheet, so patient records, exposed. Okay. And so, and then the other way is accessing legacy systems. You know, if you go to a hospital setting, they've got telemetry systems, they've got medical devices that have not been updated or changed in years. You know, and now they have a heartbeat on, they have a pulse on the network. But there's no security around it. They've just got, you know, network traffic connected to be able to transmit data, and that's it. I can guarantee you, as a cybersecurity professional, any one of you can sit in the lobby of a community-based hospital system and be able to pull data. No problem. So we talked a little bit about what we saw in 2015. You know, we see more of that happening in 2016. And as we showed, you know, last year we had 111 million patient records exposed. This year it's not going to be any different. 1 in 3 patient records are going to be victim of healthcare data breaches. Obviously, as you know, credit card data will be on decline. Healthcare data on decline. You know, I'll give you an example. In one of my previous organizations, I walked in and was looking at all the different devices that were on the network. And I saw this server, and I'm new to the organization. I saw the server, and I'm like, what is the server? It's not on my, you know, approved list. And so I went to the facility and said, you guys have a server in this location. What's it being used for? Oh, it's a server that hosts our sleep lab information, sleep lab results. And this sleep lab organization came in, they put a server there, they put a firewall there, and they're taking data elements from their sleep lab and sending those results to their headquarters. Where was IT involved in that? They weren't. Can I get access to that server? I want to see what's on that server. I want to see what kind of encryption levels on that data. I want to see where this data is going. You have a firewall here. What are the standard, what are the portfolio data on that firewall? And, you know, we need to have accountability for the data. The sleep lab told us that this data is proprietary to them, and we don't have access to it. I go back to the CEO of the hospital and said, there's this rogue device and rogue server on our network. We need to get access to it. And if not, I'm going to take it offline. Well, you can't do that. Because that sleep lab, we're able to bill $5,000 per sleep study because of that sleep lab. So now, I'm put in a very difficult situation. Revenue for the organization are compromising my network.
What happened?
Good question. I went to the CEO of the system, and we got a hold of the CEO of the sleep lab study, and we had a very candid conversation about data security. And lo and behold, within a week, I had a network administrator from the organization come walk me through the center and document it. But the funny thing was, for all you cybersecurity experts on this, the one thing that was exposed, because of this server being very sensitive and required performance to be able to send these large view settings through this pipe, guess what was missing from that server? Something very basic. You have on your home computer, antivirus on fire. So where do I see the industry? It's interesting because if you're aware, the medical center has seen an influx in conversions and implementations of primary EHR systems for Epic. Okay? In order for them to implement a system for Epic, they have to really look at the infrastructure, look at the security, look at the topology, look at the network, get rid of outdated equipment to be able to host this platform. So from an enterprise level, at least here in Houston, I can definitely say that they've taken a harder look at their security protocols, their firewalls, their infrastructure, and who's communicating that data. But what about your primary care physician? What about your specialist that you go to get your allergies checked once a year? What about the community-based hospital systems that don't have the resources, the dollars, the expertise to be able to secure their networks? So I predict that there's going to be a larger influx in that area of medicine because of the vulnerability. I went to, earlier on, I was consulting for a physician practice who was implementing EHR, and they're a small practice, they got 3 doctors and a bunch of clinicians working on it. And I asked them, so we got the server, we're going to implement it, set up the server, set up the firewall. Where is your network connection, and where's your switches, and where can we set this up? I'm not lying. You know what they said? The bathroom has a shelf. You can set it up there. Believe me, if I could go back to that practice with a laptop and knowing that I can sell that data for $500 a record, I would. So that's where you see the breaches that are going to happen more in 2016 and onwards. So one thing I didn't mention was when these meaningful use dollars came out by the government to incentivize physicians and hospitals to be able to implement EHR systems in organizations, one thing they failed to do is provide guidelines around security, around infrastructure, around how that system is going to be utilized. They just knew that you need to have an EHR system to be able to do clinical data transmission and have quality data and be able to do some metrics around the data. But how are we securing the data? That was never a criteria. Okay? So what can we do as an industry to be able to strengthen our security? The first thing is having that direct line from the chief security officer to the final decision maker, in this case the CEO. A lot of times, IT executives have a direct line to the CFO, which kind of doesn't make sense. I work for the CFO in my previous organization. Yeah, it's great when you need to sign off that PO or that invoice, but how much do you really know about IT? And so when we changed that dotted line, when I implemented Meditech EHR in our last organization, we changed that line to the CEO. And I helped her understand the vulnerabilities that organization faced, security, the Cisco firewall that we had that was no longer in support, what that really meant. Because at the end of the day, as you guys know, IT is an operational expense. It's not making them money. However, if you're shamed publicly when there's a data breach, I'm sure they're going to really take IT seriously at that point. Okay? Take a corporate selfie. Being able to look at all the devices that are in your organization every device in the healthcare industry now pretty much has a external or internal network jack or community wireless. So going back to the instance I gave with the sleep lab, to me that was a perfect selfie. I was able to see what's out there on my network that I don't have control over. Cover basics, right? What we talked about in the end, encrypt laptops, patches, like as I mentioned. Some of these organizations have, Windows NT environments, no longer supported. But yet you're running mainframe systems on them that have patient health information. And secure passwords. Do you know how many times I've been at a nurse's desk and that password is underneath your keyboard? Learn from other industries, right? Retail industry, finance industry. They learned the hard way when it came to data breaches. Learn from them and see how you can improve. And bulletproof BYOD. Okay? That is a big issue right now in healthcare as well. Every clinician, every patient is coming with multiple devices. Anyone can get into that device. There's the, you guys know, all around BYOD. And that's one thing that healthcare area fails. They know they need to have a BYOD solution, but they just don't know how to manage it and secure it. And wireless, because everything, sorry, go ahead.
So, on your first point with the CFO, I agree you shouldn't report to them, but I think things are getting for the better in that industries are starting to find and the set for non-compliance to standards that the CFO does understand. So definitely HIPAA, the PCI industry is coming forward with that, saying once you're audit, if you're not compliant, you're going to pay whether you have a breach or not.
Correct. And so that's a great point. And so the education obviously is increasing at that level. However, as you know, IT is a standard that security is a standard that everyone in the organization should hold, not just the IT professionals or the CFO. Right? The CEO needs to be accountable for it. The board needs to be held accountable for it, along with anyone else at C-suite executive level. So, in my mind, I think that the IT role should really be, yes, the CEO, the dotted line to the CFO, and the dotted line to the chief operating officer as well. Okay? And then along with BYOD, secure wireless. I've been to physician offices, and I'm sitting in the waiting room, waiting to be seen with the physician, and I'm bored, so I'm on my phone, and I see unsecured wireless. And guess who it is? It's my doctors. Oh, this will be fun. Right? And then, so, going back to the opportunity for breaches in 2016, that's where those breaches is increasing. So what are we doing as an entity, as Greater Houston Health Connect? We're performing our risk assessment, which really outlines where you are, where you ought to be, right? And that risk assessment, going back to the board, is actually presented at the board level. So, and my board is consisting of C-suite executives from the medical center. So I'm held accountable to where my risks are in our organization. Review vendor and customer agreements. That's really important. Take a look at, who's being held accountable and what are they doing in terms of data breaches. Security awareness. So I was mentioning earlier on that everyone should be exposed to security and understand the vulnerabilities of security. And so we're constantly having education and training within our organization to be able to train our staff on what to look for when it comes to data protection. Oh, you've got a secure file for MD Anderson. Where are you going to download that on your laptop? Even though it's secure, I just rather not have it on my network. Okay, so think to that mentality. Because we're talking about not one patient record, we're talking about thousands of patient records being exposed. Establish a security framework, and we're talking a little bit about high trust. And then also, the board. So going back to our board, there's actually a security subcommittee, which is actually chaired by Tim Tindall, the CIO of Harris Health. Okay. Now we're running a little bit out of time here, so just talk a little bit about high high trust. So you saw the breaches and who are the culprits? Well, guess who's now enforcing a new common security framework? It's some of those same insurance companies that have those data breaches. Okay? It's mandated that all business associates doing business with these entities and more go through high trust certification process. Okay? What's great about high trust, I'll show you a diagram about this, but it actually harmonizes HIPAA, PCI, ISP, and NIST. Okay? There's about 19 different domains that are reviewed in the security framework, which include endpoint portable media, mobile devices, wireless, vulnerabilities, passwords, and so forth. So just those examples that I gave you are now being scrutinized within this common framework. And then there's a process of a self-assessment, remediation, validation based on the self-assessment, and certification. So some of the benefits are obviously to reduce risk of non-compliance and scalable. It provides clear and accountable guidelines, and also it's ever evolving based on regulations. So this little diagram here shows the coverage that high trust has now. So what's great about this is that you can actually run a report that's specific to, let's say, HIPAA or to your ISO standard, and be able to extract that data strictly for that standard and that framework within this high trust application. So some of the challenges for high trust. A, it's mandated. So we all know that executives do not do well with anything that's mandated. Number two is the cost, the expense of going through this high trust certification. It is for small businesses roughly $30,000 to $40,000 to go through the certification process. So imagine now you're a small organization doing business with United Health, and now you have this additional expense of going through the certification process. What does that really mean to your bottom line, and how beneficial will it be for you to do business with United? Timeline. It's 24 months to be able to go through a gap analysis, remediation, and assessment. I'm going through that right now. That 24 months feels like 24 hours. Okay, it can't come soon enough, and I'm not prepared. And then scalability. You know, the applicability for small business and multi-organization, multinational organization. This standard is good in the United States, but what about if we're an entity that's doing business at an international level? The same standards are not applied. Okay, so these are some of the challenges we're facing. There is a framework around it. I've reviewed it. It's a great standard. I think that we're looking forward to being able to meet these certifications. But these are some of the barriers that we're dealing with as well. And now we're seeing not only from the insurance organizations, but we're also seeing mandates from other hospital systems. So we're actually about to bring Texas Children's Hospital on board, and their director of security says, Deepak, is your organization high trust certified? I said, no. Well, guess what came up in the contract? That you must meet high trust certification within 24 hours of engagement of this contract. Okay? So hospital systems are holding us accountable to meet these certification mandates. So I know we're stuck for time, and I'm going to wrap up with a final thought. So us as patients are going to our hospitals thinking that our data is secure. We're thinking that there's a level of accountability for data breaches. What I've outlined to you at a very high level that there really isn't much accountability. Because if I know that if I have enough insurance, I'm covered. What we need to see is more regulations regarding data breaches. We need to see insurance companies that are insuring these organizations to regulate. And we also need to see patients as a community say, am I covered? Am I protected? How do I trust that my data is not going to be exposed? Because guys, if any of you guys have ever had your credit card stolen or your identity stolen, you know what kind of nightmare that is. Imagine your health information being stolen and what you would have to go through to be able to track all that information back. And what kind of fraud can happen. manipulation that data can have. So at this time, I'll take some more questions.
Any questions?
Yes, sir.
Audits, things that are external to that. You're connected to networks that are outside, things that are networks that are elsewhere.
So
Are you going off doing things like, what's the thing you're doing next?
So from the state level, yes, we are doing auditing. A lot of logs are being sent to us from that connection for HIE Texas. And auditing and having the same who's querying us. Because at the end of the day, if there's a physician in Colorado querying for data that's in the Anderson, and the Anderson wants to know, why is that physician querying data on a patient here in Houston? So we're having to provide those audit trails, both at a security level and at a user level as well. Anything else?
Any other questions?
I hope this was informative.
It was fantastic. Let's just give people the applause. People, we should probably be here for a second time. I just got a couple of closing thoughts. But that was, I mean, I really learned a lot. That was just a great presentation. Thank you so much. One more hand, please. Okay. So we've got our raffle drawing, and that's going to be brought to you by our sponsor. So the first sponsor up is Renee Apples.